My dear students, in this video, I am going to discuss a few points about treating biofilms and antimicrobial resistance. Now, antimicrobial resistance is one of the gravest challenges for the intensivists across the globe. And despite having many potent antibiotics, we face antimicrobial resistance because of biofilms. Now, biofilms is an ecosystem of sessile bacteria surrounded by uh, self-produced matrices, which are polymeric material, which the antibiotics are unable to penetrate or penetrate very poorly, leaving the bacteria or the sessile bacteria at large. So, therefore, they survive the antibiotic effect and can continue to produce infection and also cause recurrence. Let us start with a case. A 62-year-old male diabetic was admitted to the ICU with septic shock secondary to COTI. Initial urine culture sensitivity grew Klebsiella pneumoniae, which was sensitive to meropenem and piperacillin tazobactam. He improved with 8 days of therapy, but relapsed within 2 weeks after discharge. Repeat cultures grew Klebsiella pneumonia again, and this time it was resistant to all beta-lactams and fluoroquinolones. On ultrasound, biofilm incrustation was visualized along the indwelling Foley's catheter. Biofilm associated infection was suspected, and catheter removal with antibiotic lock therapy was initiated alongside IV colistin. So, how infections with biofilm continue to evade antibiotic therapy? So, biofilms are nothing but microbial ecosystems which are adhering to the surfaces like the catheters, endotracheal tubes, prosthetic valves, or mucosal tissues. They consist of bacteria embedded in the extracellular polymeric substances, which we conventionally call EPS, and which is made up of polysaccharides, proteins, DNAs, and lipids that go on to form a protective matrix to those bacteria which are harbored inside. So it takes successive stages for the biofilm to form. In the first stage, this planktonic bacteria, they attach to the surface, and this initial attachment is reversible. After some time, there is cell aggregation and accumulation in layers, and they form the matrix and surface adhesion. So this matrix surrounds the bacteria and they get covered within it. Next is the stage of biofilm maturation, where the biofilm growth and cells structurally and metabolic heterogeneity. And this is the time where they go, where they create the quorum sensing. Quorum sensing is the technical term. So this quorum sense, they can code for the genes, which will continue to express the bacteria within this biofilm. And the fourth stage is the stage of biofilm dispersion, when the cells from this biofilm get dispersed into the planktonic cells. These cells get dispersed and reach new surfaces where again they can start maturation, multiply, form biofilm, and so on. So, how do these biofilms contribute to bacterial resistance? One, they act as a physical barrier and thereby impede antibiotic penetration. Two, these bacteria deep within the biofilm enter a slowly growing and metabolically inactive state. And as because the antibiotic bacteria which are actively multiplying, actively grow, which are involved in active processes. So this slow growing or metabolically inactive state of the bacteria renders them less susceptible to the action of antibiotics. Third is the horizontal gene transfer, that is close bacterial proximity facilitates plasmid-mediated resistance to develop. 4. The persister cells. A small subpopulation of these bacteria survives antibiotics, and from time to time, they lead to relapse. And last but not the least, there is an altered microenvironment induced by these biofilms for which the pH shifts and there is hypoxia, which impair the antibiotic efficacy. So if we look into our case, the biofilm formed on the Follis catheter acted as a reservoir of infection. While systemic antibiotics eradicated the planktonic bacteria, the sessile cells within the biofilm persisted and accelerated the evolution and selection of the resistant clones, for which we had no choice but to use colistin IV, and we had to use antibiotic lock therapy. Now, what mechanisms link biofilm and antimicrobial resistance? One is the extracellular matrix, polymeric surface matrix barrier, which prevents antibiotic diffusion. And the clinical implication of this pathology lies in the requirement of high local concentrations of the antibiotics. Second mechanism is quorum sensing, as I told you, which is occurs during the phase of biofilm maturation, which regulates resistance gene expression. And therefore, this bacteria acquires resistance to the antibiotics. And therefore, the clinical implication is the need for antibiofilm drugs which can target the sites or the biofilms. Third is the persister cell formation, that is survival under antibiotic stress, as which I have already stated, that because of their hypoactive state or metabolically inactive state, they become less susceptible to the action of the antibiotics because the antibiotics target the rapidly multiplying and the metabolically active cells. So because of this, the clinical implication is the chronic recurrence, which occurs in such patients with persistent cell formation. Next is the genetic exchange, that is the spread of plasmid-borne resistant genes, because when they come to lie side by side, so many of the bacteria within this biofilm, they can spread the resistance genes, and the clinical implication is the occurrence of MDR outbreaks due to such resistant genes. And fifth is the altered metabolic state leading to reduced uptake of the antibiotics. So the clinical implication being that there is need for combination or metabolic activators during treatment of biofilms. So what key remedial measures are likely to benefit? One is mechanical removal, so that the surface on which the biofilm is formed can be thrown away. It is crucial. Monotherapy often fails against biofilm-related infections. And third is combination therapy or localized high-dose antibiotic exposure like lock therapy or antibiotic lock therapy, which we've practiced, may be required. Let us come to another case. A 48-year-old female with diabetic foot ulcer presented with foul-smelling discharge. Despite repeated dressings and systemic antibiotics, peptides, then meropenem, the healing was slow. The tissue biopsy revealed a mixed flora of Pseudomonas, Staph aureus, and Enterococcus faecalis in a dense biofilm matrix. Surgical debridement followed by topical silver nanoparticles and negative pressure wound therapy led to progressive healing. So, what should be our approach in such patients? So, chronic wound infection and the challenge of debridement is particularly noted when there is biofilm. The chronic wound infections exemplify the multi-species biofilm problem that we noticed in this case. And within this biofilms, the bacteria exhibit synergistic resistance, where metabolites from one species neutralize the antibiotics of another species against another. Like Pseudomonas secretes alginate and protects the neighboring staphylococcus cells from immune attack. Therefore, biofilm targeted therapy requires both physical removal, which was done here by surgical debridement in this case, as well as antimicrobial agents with anti-biofilm activity, such as silver nanoparticles, which was used here, acetic acid, honey-based dressings, photodynamic therapy, then enzymatic agents like DNase, dispersin B, etc. So, what are the emerging therapeutic approaches against biofilm? One is the combination and synergistic therapy. Antibiotic combinations exploit synergy against biofilm bacteria. For example, rifampicin and vancomycin can be combined for staphylococcal prosthetic infection. Colistin with rifampicin can be combined for carbapenem-resistant gram-negatives. Beta-lactam can be combined with aminoglycosides for enhanced penetration. Now, we have to remember that rifampicin is a drug which is under the reserved category in India, so it will not be useful or available always for use. But we can use similar drugs, and there are other drugs also which are being tried and tested for the synergistic effect. Second is the antibiotic lock therapy, which is used in catheter-related bloodstream infection, where a high concentration of antibiotic solution is instilled in the catheter lumen for several hours, that is up to for 4 hours, and it should be 100 times more than the concentration which is required for the MIC. So if it should be kept for that, that can eradicate the sessile biofilms. Agents include gentamicin, ethanol, or taurolidine. They are commonly during when they can be instilled, and along with these antibiotics, usually heparin solution is also injected into those lumen, and then they are locked so that this solution remains in the lumen, inside the lumen for 3 hours or 4 hours, and all the bacteria get killed. In addition, there are other physical and mechanical strategies like ultrasound enhanced antibiotic therapy, because ultrasound, the low beam ultrasound 100 hertz, they will favor or improve the penetration of the antibiotics into the biofilms. Then negative pressure wound therapy, that reduces the bacterial burden and the biofilm biomass. So that is also useful. Laser and photothermal therapy, which can directly disrupt the matrix structure and expose those sessile bacteria to the antibiotics, has been also been found to be useful. In addition to that, some new antibiofilm agents are under investigation, like quorum sensing inhibitors, which block the bacterial communication, like furanones, azithromycin in sub-MIC concentration, enzymatic dispersal agents, which degrade the extracellular polymeric substance, which is the matrix, that is the DNase 1I and the dispersin B, bacteriophage therapy, which target the bacteria with biofilms, like Pseudomonas aeruginosa phages. Then antimicrobial peptides, which can disrupt the membrane, like LL37 and colistin derivatives. And of course, nanotechnology, which with targeted drug delivery, like liposomal or silver nanoparticles. Recent studies have also showed success with immunomodulators that enhance phagocytic clearance or interfere with bacterial adhesion, like anti-adhesin antibodies, cytokine modulation, etc. Now, whenever we use this, is a bit interesting. As you can see, the ultrasound enhanced antibiotic therapy on the probe ultrasound emits the ultrasound waves, which is directed at infected tissue or the biofilm. The tissue contains bacteria. In biofilm infections, these bacteria are protected by the extracellular material, which reduces antibiotic penetration. The ultrasound waves cause microstreaming and cavitation, which temporarily increases the cell membrane permeability and disrupts the biofilm structure. This mechanical effect helps the antibiotics to enter the bacterial cells more effectively and attain the necessary concentration that it can kill them. And these blue capsules represent the antibiotics, which you can see in the figure. Because of ultrasound action, antibiotics can now diffuse more easily into the bacterial microenvironment and exert a strong antimicrobial effect elsewhere as well. Let us go to the third case. A 70-year-old male developed ventilator-associated pneumonia on day 8 of mechanical ventilation. Sputum culture revealed Acinetobacter baumannii, which is resistant to carbapenems. Despite colistin, clinical response was poor. Endotracheal tube analysis confirmed thick biofilm formation. Therapy was modified to include aerosolized colistin, biofilm disrupting agents, and frequent subglottic suctioning, and there was gradual improvement. So, ventilator associated pneumonia is often sustained by endotracheal biofilms where pathogens evade antibiotics and finally recolonize after locating into the lower airway. So, what should be the preventive strategies? There are certain preventive strategies against the biofilm formation, like the silver coated endotracheal tubes, subglottic secretion drainage, regular tube exchange protocol, selective digestive decontamination, etc. There is some ambiguity about one or two, like the silver coated and the selective digestive decontamination, but by and large, it is seen that they have either minor or major role in prevention. In this case, aerosolized therapy provided at high local concentration, that is the colistin nebulization, overcoming the diffusion barriers, which is an essential step in biofilm associated pulmonary infections. So if we make a summary of the three cases, we find that in the first case, it was catheter-associated infection. The primary challenge was MDR Klebsiella biofilm. The intervention was catheter removal with antibiotic lock therapy, and the outcome resulted in eradicated infection. The second was a chronic diabetic wound with mixed species biofilm. The intervention was debridement with silver nanoparticles, and there was progressive wound healing. The third case highlighted a carbapenem resistant Acinetobacter baumannii biofilm. Ultimately, the intervention was aerosolized colistin and secretion control, and finally, the infection resolved. So, there has to be global strategies against biofilm and antimicrobial resistance, the first and foremost of which is antibiotic stewardship. Unchecked use of broad spectrum antibiotics promotes biofilm resilience and antimicrobial resistance, and therefore, stewardship programs must prioritize narrow spectrum use guided by cultures, limit indwelling devices, encourage early source control, and monitor antibiotic exposure duration. Second is the infection prevention. Preventing device-associated biofilms can be achieved through aseptic insertion techniques, routine lines replacement, antimicrobial coated catheters if feasible, and education and hygiene compliance. The third is through research and innovation, that is ongoing research was focuses on, this is called CRISPR-Cas9, which is base disruption of resistant genes, biofilm vaccines targeting surface adhesins, then phage antibiotic synergy, that is the PAS, and AI-guided drug discovery for antibiofilm molecules. So we can adopt a stepwise based approach. In the first step, identify the infection source, which can be an object like catheter, wound, airway, etc. So in the step 2, you remove or replace the device to reduce the bacterial load. You debride or irrigate to break the physical biofilm. Administer systemic plus local antibiotic combination to overcome resistance by building up the concentration. Add antibiofilm adjuvants to inhibit quorum sensing and also to degrade the extracellular polymer substance. And the next step strategy is to monitor and de-escalate to prevent further resistance. There are some challenges and also as well as future directions despite promising advancements. These barriers include limited clinical translation of laboratory and biofilm findings, difficulty in standardizing biofilm susceptibility tests, heterogeneity of biofilm species, which can complicate the targeted therapy. Finally, we have to go for targeted therapy in all patients. and economic disincentive for pharmaceutical investment in anti-biofilm drug. It makes no very difficult to believe that more we make the weed, ultimately lesser will be the scope of using antibiotics. So, however, with growing interdisciplinary interest, microbiology, nanotechnology, and immunology, the landscape is evolving towards precision and also towards antibiofilm therapy. So, the key takeaways should be that source control is as crucial as antibiotic choice. Combination therapy often outperforms monotherapy. Antibiofilm adjuvants and localized therapies are the future, and stewardship and device management remain the cornerstones for antimicrobial resistance prevention. To conclude, treating biofilm associated infections in the era of antimicrobial resistance demands a paradigm shift from antibiotic centric therapy to multimodal, source oriented, and biofilm aware management. Biofilms not only protect bacteria from antibiotics but also foster resistance evolution. Therefore, as I repeat, effective management strategies are early identification of biofilm related infections, aggressive source control, combination of local antimicrobial strategies with rational antibiotic stewardship. The future lies in integrating nanotechnology, phage therapy, quorum sensing inhibitors, and host immune modulation into clinical practice. But till then, it is only through vigilance, stewardship, and scientific innovation we can keep ourselves abreast, and they remain our best weapons against the intertwined threats of biofilms and antimicrobial resistance. Thank you.